afternoon, everyone. I'd be surprised if anybody's good evening, but welcome to all, and thanks very much for your interest in learning a little bit more about diagnostic error. A word first about my organization, the Society to Improve Diagnosis in Medicine. We are a nonprofit group. It's international. We're based in the US, it's physician-led, and we're the only organization focused on this problem. We envision a world where diagnosis is accurate, timely, efficient, and safe, and a world where no one is harmed from diagnostic error. I'd like to invite everyone to attend our conference. It's coming up this fall in Los Angeles and Hollywood, a wonderful venue, and we would love to see some of you there. I'd like to start off telling you about a case that occurred in the US a couple of years ago. It was in all the papers in our country, and it illustrates many of the main features of diagnostic error that I'll be talking about. The case involves a 12-year-old boy, Rory Staunton, who was at school and accidentally scraped his knee during recess. Didn't think much more about it. But several nights later, he awoke. He didn't feel well. He woke up his parents. He was having chills. He vomited, and the next day he felt worse. They were able to take him to see the pediatrician, and at the pediatrician's office, she got this story of fever and vomiting, some pain where he had scraped his leg, had a temperature of 102, his heart rate was very fast, 140, was breathing quickly, and his skin appeared mottled. We don't have a picture of that, so this is just a stock photo of mottled skin. It's kind of an alarming finding when you see it. We don't see this very often. The abdomen was described as benign, but the pediatrician, hearing this story of fever and vomiting, said, "I think you have gastroenteritis, a stomach flu." And she recognized that he looked a little punk. She called up the emergency room. "I'm sending over Rory, he's got gastroenteritis. Please look him over and give him some fluids." So he went to the emergency room, and this is one of the best hospitals in our country, and they got essentially the same history, the same physical findings. Very high heart rate. Again, his abdomen was benign. The skin exam was not documented at the ER visit, and they said, "Yeah, sure, gastroenteritis," and gave him some medications for nausea and vomiting, and gave him some IV fluids and sent him home. After he had left, his blood test results came back, and I don't know if it would have changed anything, but he had a mild elevation of his white blood cell count, nothing too striking, but he did have a significant number of bands in the blood, which is atypical for a viral process and suggests more of a bacterial process, something different than gastroenteritis. He didn't do well. The next day, he was more sick at home. Family described his skin as looking terrible, more blotchy, blue with red spots. They tried to get back to the pediatrician with no success, got some indirect advice just to take some Tylenol, paracetamol. They couldn't stand it the next day. He just looked horrible. They took him back to the emergency room where he was immediately admitted straight to the intensive care unit, and he died the next day of streptococcal sepsis. So it's very likely he did not have a viral gastroenteritis, that these were all manifestations of streptococcal sepsis acquired from scraping his leg 5 days earlier. It's an illustration of diagnostic error, and a tragic one. This is what I'd like to cover today. How likely is this problem of diagnostic error? Why do these errors happen? What are the major causes? And to understand that, we'll have to back up a little bit and discuss how do doctors think and what goes wrong in that thinking process. And we'll finish up with considering what we could do to address the problem of diagnostic error. Fortunately, some of the work, a lot of the work has been done for us. The Institute of Medicine in the US just issued a major report, almost 500 pages long, on diagnostic error last September. Here it is. It's called Improving Diagnosis in Healthcare. And I'll be summarizing some of the conclusions and recommendations from the report. But the important part about all this is that it's just a report. It doesn't really change practices, which is what we need to do to see fewer of these errors going forward. So the whole goal of this presentation is to think about what we could do to change the way we practice. What can physicians do differently? What could we do different in our healthcare organizations or in our national efforts to improve quality and safety to make this a safer world? This is the definition of diagnostic error that was presented by the Institute of Medicine. It's a new one. There's 3 other definitions out there, so this one is unique. They define diagnostic error as a failure to establish an accurate and timely explanation of the patient's health problems or communicate that explanation to the patient. And I've highlighted a few things here. I've highlighted patient. It's in here twice, and it's not in any of the other definitions of diagnostic error. So it's a patient-centered definition, and much of the IOM report is centered right on the patient and how we can improve the patient's experience and their outcomes. I've also outlined some things in blue. So what does accurate mean? These are all things that need more research. What is accurate? How accurate do we have to be? Is it accurate enough to say somebody has got small cell lung cancer, or do we have to know the genotypic makeup of that particular cancer? What do we mean by timely? How long should it take to diagnose sepsis or cancer or anything else? We don't have any guidelines in medicine for how long diagnosis should take or how long it takes on average. And what do we mean by communication? It was very controversial whether this should be in the definition at all, because some people said, well, that's different. That's the next step. But I'm glad it's in there because communication is huge. It's the #1 problem in every study of diagnostic error. In fact, #1 problem in every study of patient safety in general. Communication breakdowns are so problematic in healthcare. We need to address that. And it brings to mind this quote that's been attributed to George Bernard Shaw. The single biggest problem in communication is the illusion that it has taken place. We all think we do a great job communicating with our patients, but if you survey them afterwards, we find that there were many deficiencies, and they wish there had been more communication or that it had been more clear. It also brings to mind, and this is what was convincing to me, a study by Eric Poon several years ago. He surveyed 168 primary care providers in the US. They all had a very nice electronic medical record system. And he asked them, do you have a reliable system for tracking test results that you've ordered on patients from start to finish? Only half of them did. They kept no record of tests ordered. And in the past 2 months, can you recall at least one test result that upon review you wish you had seen the results earlier? 81% related that they had one or more significant delays in the past 2 months. So communication issues are prominent and common. Let's talk about the incidence of diagnostic error. What do we know about that? Well, here's some data again from the US. This is a compilation of 584 cases reviewed by CRICO. It's a risk management company in the US that collects cases, malpractice claims concerning different types of medical errors. And in their 584 high severity claims, by far the most common reason for a malpractice claim was diagnostic error, and this accounted for the largest financial outlays in terms of settling these cases. Here's some other facts and figures, all from research studies about the incidence of diagnostic error. Again, these are all from the United States. Using secret shoppers, there's data that 1 in every 10 diagnoses is just wrong. From autopsy data, it's been estimated that there are 40,000 to 80,000 deaths every year from diagnostic error. In surveys, 1 person in 3 says yes, they've experienced a diagnostic error themselves or a member of their immediate family. And we've just seen the kind of claims data that shows that it's the #1 cause for claims in all of the major insurance databases in our country. And a recent study using chart reviews by Dr. Hardeep Singh found that 1 in every 20 patients seen in a primary care setting will experience a diagnostic error every year. So if your odds are 1 in 20 every year and you live to be 60 or 70 or 80 or 90, the odds are overwhelming that this is going to affect us. And this is how the IOM phrased it. Most of us will experience at least one diagnostic error in our lifetime, sometimes with devastating consequences. This is what it adds up to in my country, in the US. There's that 40,000 to 80,000 deaths a year. That would put it in the top 10 causes of death. And if we divide this by the number of hospitals, there's some 5,000 hospitals. It means that in every hospital, there's 10 deaths every year and 10 patients harmed every day in ambulatory care settings in the clinics or in the emergency rooms. And what do we know about diagnostic error in a global perspective? And I think the honest answer is we don't know very much at all. There's very little data. But if we had to guess, I think the answer would be it's got to be at least as high it is in the US and probably more. UNICEF estimates that there are 7 million children internationally that die each year from treatable and diagnosable infections. We know that delayed diagnosis of cancer is a ubiquitous problem around the globe, and that even common chronic conditions, hypertension, diabetes, glaucoma, the diagnosis of all these things is suboptimal everywhere. So it's a big international problem that affects all of us in every country. Here's another problem that we deal with, I think, everywhere, and that's the fact that we don't really get very good data on feedback. So in the US, autopsies used to be a common thing, and I know that in some countries they're still performed regularly, but they've disappeared in our country, largely because they aren't paid for anymore. So physicians don't get that kind of feedback, and there was nothing more meaningful than seeing your own patient on the autopsy table to remind you that diagnosis is fallible. So if our first question was how likely is diagnostic error, the answer is it's more likely than we'd like it to be. It's probably 10% or even higher, and it occurs at an appreciable rate, causes enormous harm and costs. And we perceive this rate to be low because most errors are inconsequential, we don't get direct feedback, we underestimate the risk, and we're overconfident about how sure we are about what's going on and our diagnostic skills. Where do these errors happen? This is again data from FRICO. They looked at a much larger cohort, over 4,000 malpractice claims related to diagnostic error. And the biggest chunk of the pie is ambulatory care. It was kind of surprising to me. I would have guessed it was going to be the emergency room. But if you think about it, the bulk of medical care is delivered in ambulatory settings. And sure enough, that's where most of the diagnostic errors occur. Yes, many in the emergency room. The emergency room is not a great environment for making diagnosis. There's pressure, there's stress, there's often chaos, there's lots of things going on. We have incomplete data on the patients, and for many reasons, it's kind of the petri dish for diagnostic error, and about a quarter of these errors arise in inpatient settings. One thing we've learned from these studies is the kinds of conditions that predispose you to diagnostic error. And certainly if you have a rare condition or something that presents in a very atypical fashion, you're at risk. But all of the data we have says that it's really the common conditions that make up the bulk of diagnostic errors. It's people with anemia or asthma or COPD where there's delays and wrong diagnosis occurring on a regular basis. Let's talk about the cause of these problems. How do they arise? And let's start off by acknowledging the fact that diagnosis is really hard. There's probably nothing more complex than diagnosis as a cognitive effort. And part of the problem is that there's so much variability and complexity in every single part of this. So there's patient variability and physician variability and system complexity that contributes to making this an extremely difficult and challenging assignment. And how many diseases are there? There's a huge number. According to the World Health Organization and ICD-10, there's over 12,000 different diagnoses. According to the National Library of Medicine and their mesh system, there's over 8,000. And what's kind of fun is you can go to the NLM site and see the new diseases that are added. So there's 100 or 200 diseases that are added every year. How good am I going to be at diagnosing a disease I've never seen or never even heard of? These are just 4 of the new diseases that were added a couple of years ago. The yellow nail syndrome, the alien hand syndrome. These are all probably very rare, but they're very real. And patients have these conditions and are at very high risk of being misdiagnosed. This is how I analyze cases of diagnostic error. I didn't invent this system. It's kind of a classical way to look at any healthcare problem. So here's the patient going along their clinical course at the bottom, and there's harm. There's a diagnostic error. That's the sharp end of medicine. And it's perfectly appropriate to look at me and say, Mark, why didn't you diagnose that case of sepsis? You know, that really wasn't gastroenteritis. And it leads to a discussion of the cognitive errors that contribute to these problems. But many people would say, and in fact the IOM would say from their initial report in 1999, forget about the sharp end. We should focus on the system, the healthcare system, because this determines in large part the success of healthcare delivery, its quality and its safety, and how well we do with diagnosis. So how well we do with communication and coordinating care, training, orientation, policies and procedures. All of these things are extremely important. I studied 100 cases of diagnostic error and tried to understand what were the root causes. This is what we learned. Most often it's both things going on at the same time. In any single case you can identify both system problems and cognitive problems. But if you ask how often is there a cognitive problem, it's the sum of that blue piece of pie and the yellow one. So, 2/3, 3/4 of the time there's a cognitive issue. And similarly, 2/3 of the time there's a system issue contributing to diagnostic error. These were the most common system-related problems that we saw in my study. Communication problems were at the top of the list. For example, a lab test was lost, or providers didn't share information effectively. Coordination of care was a problem. Medical records might not have been available. Expertise wasn't always available when it was needed. Lots of problems with culture and supervising trainees, and you can see the list of things here. An important one to point out is workload. Some people would say, at least in ambulatory care, the biggest problem in regard to diagnostic error is that we just don't have enough time to spend with the patient. The workload that's assigned to us is just too large, and that 10 or 15 or 20 minutes that we have isn't quite long enough. A striking thing that was apparent to us in our study was the phenomenon of normalization of deviance. Lots of big words there. But it meant that in any healthcare organization, or at least the ones we looked at, everyone just got used to the fact that this is the way it is. Yeah, we know there's no radiologist on call at night. Yeah, we know that clinic visits are limited to 15 minutes. And there was no effort to address that as something that might improve diagnostic quality and safety. Okay, so let's talk about the cognitive errors, and these are the most interesting to me because as a physician I think this is what's under my control. These are the things that I could conceivably change in the way I practice. So what are the biggest problems in regard to putting everything together or gathering the data or knowledge base? And very clearly in our study, the biggest problem is in the synthetic phase. So we have enough data and we have enough medical knowledge, we just don't put it all together correctly, which is kind of puzzling. How does that happen? If we think about what causes diagnostic error in other parts of the world, especially in low and middle income countries, there's many other factors that come into play besides those that we identified in our studies in the United States. And I'm sure you're all familiar with these. The burden of disease is enormous. There's not enough medical staff. The diagnostic testing resources are insufficient. Limited access to specialists. Rudimentary quality management programs. So the challenge grows as we move outside of the US and start to think internationally. All right, let's get back to those cognitive errors. How do those happen? And we have to start off with the question, how do doctors think? There's a cognitive scientist in the US, his name is Arthur Elstein. He studied this for his entire professional career, 30 years. He gave doctors scenarios and watched how they solved the cases. And he didn't exactly answer the problem, but he simplified it. He wondered, do doctors think at all? Because he was thinking, well, diagnosis is so important. Surely doctors take the time to stop and think and make a complete differential diagnosis and pursue everything rigorously, and that's not what he saw at all. So here's an example. Say we're in clinic and in comes a middle-aged gentleman who looks bad. He's got fever and muscle aches and cough for the last couple days, and everyone at work is sick too, and it's right in the middle of flu season. So what does he have? Well, I think most of us would in a snap say he's got influenza. Very unlikely to be Lassa fever and Schmickeldorf syndrome. Who knows what that is anyway? So this is typically how diagnosis is accomplished. We just recognize what's going on, and that process takes place immediately. It's highly successful, and it's very widely used. This is the current paradigm for how doctors think. It's the current paradigm for how we all think. It's the paradigm for how we solve every new problem we confront in life. So it starts off with the recognition center. Do we recognize this problem? And most often we do, which means that we revert to what we call system one, the intuitive pathway. This is the pathway that experts use. And because we recognize what's going on, we immediately know what to do. So in the case of medicine, it means we know the diagnosis and we're done. We're moving on. Life is short. If we don't recognize what's going on, we have to stop and think. And we revert to the rational pathway, system two. It's deliberate. It involves conscious thought. It takes time. And we don't like to go that route if we can avoid it. So here's a little quiz. Just think about whether you recognize these entities on the screen. What's that thing up in the upper left? Well, boom, you know, we all know that's a telephone. Even though none of us had a telephone that was quite that ugly or maybe had that shape. But we recognize its features. And that's system one, the intuitive pathway. We recognize it. What's that thing in the upper right? Same story. Recognize it. It's a can opener. Okay, lower right. What's that one? Ooh, oh no. Well, it turns out that's a can opener too. It's been reimagined. And that one we had to stop and think for a minute. And how about the lower left? Not sure what that is at all. So this is an illustration of the intuitive pathway versus the rational pathway. And we use both of them in medicine to a large extent, but in too many cases, it's solely the intuitive pathway that dominates. And you can see how that might have been working in the Rory Staunton case. He came in with fever and vomiting. Okay, intuitively, that evokes a picture of viral gastroenteritis. So we're talking about these mental shortcuts that we all use. The technical term is heuristics. To our intuitive pathway and pattern recognition. And these are just some of them. Over 100 different heuristics have been described. You can go to Wikipedia or one of Pat Proskeri's articles and read all about these. They are human traits that we all use and we employ them every day. So to diagnose influenza in our patient, we use what they call the availability heuristic, the recognition heuristic. And it's extremely beneficial. It's fast, it's effortless, and it's very often correct. And the reason it's correct is because it approximates the base rate of disease in the population of patients that we see. In other words, the vast majority of people that we see in the middle of flu season coming in with fever and sore throat and achy muscles have influenza. But it's not perfect, and this is the problem with every heuristic. There are drawbacks. We don't stop to think of what else this could be. We don't make a differential diagnosis. Hardeep Singh has an interesting study. He looked at a large number of cases of diagnostic error. 80% of the time in the medical record, there was no differential diagnosis. Just as in the Rory Staunton case, there was just one explanation, gastroenteritis. Other drawbacks, our experience is limited. Maybe we haven't seen a case of Lassa fever or Schmickeldorf syndrome. And just because we think it's right doesn't mean that it is. Here's an illustration of the availability heuristic. Just quickly, what do you think is more common? R as the first letter of a word or R as the third letter of a word? Think of your answer. Okay, well, when I first saw this, I said first letter because my exercising typing class was roll over, red rover. It was easier for me to think of words that started with R, and that's the availability heuristic that led me to that answer. And that's the wrong answer. As it turns out, R as the third letter is 3 or 4 times more common. But it's harder for us to think of words where R is the third or fourth letter. We would have to stop and think. If you're not convinced that we should not trust our intuition, here's a little vignette for you. I'd like you to think back to the last time you took a multiple choice test. And we've all done this to get into school or to pass an examination. What advice were you given? To trust your intuition as you're marching through these questions, or to go back at the end of the test and reconsider the questions you weren't sure about? What advice were you given? Well, many of us were told to trust our intuition, and many of us still believe that, but here's the facts of the matter. We did a study of thousands of residents in the United States taking their internal medicine boards. So they're about to go into practice. They're as smart as they're ever going to be, as full of knowledge as they will ever be. And we could track when they were taking the test whether they went back to look at their answers and re-examine them and change them. And this is what we've found. they are twice as likely to change a wrong answer to a right answer as vice versa. Twice as likely. So going back and reconsidering their choices led to better scores and better outcomes. So here's our study down on the bottom row there, done in 2012. And in the last two columns, you'll see that you're twice as likely to get a right answer as a wrong answer. But silly me, I hadn't looked back through the literature. This exact same thing had been done many times before with the exact same findings. So in all of these studies, where are in high-stakes situations, high-stakes exams, you are twice as likely to get the right answer if you go back and reconsider your options. So intuition is great. It gets us through our everyday lives. It solves medical problems. It's how we make diagnoses, but it's fallible, and it can be improved upon if we just stop and think. One last illustration of the intuitive pathway for you all. I'd like you to stare at this screen for a minute and see if any of these things are moving around. Are they rotating? Well, for most of you, they will be. And I have no idea why this happens, nor does anybody else. It's your intuitive brain that's making this happen, your subconscious parts of our cognition system. And that's what we're talking about in terms of diagnosis. We're making these diagnoses, which are so important, using a part of our brain that we don't really understand at all and can't really study. So how do doctors think? For the most part, it's this intuitive mode, and it works extremely well, but it's not perfect. It's error-prone. And it's my argument that diagnosis is just too important to rely solely on intuition. So let's go back to the Rory Staunton case and see if we can analyze it. What were the system-related problems? What are the cognitive errors? Let's look at the system things first. Yeah, the lab results should have been back sooner. Another big problem, there was not a good plan for follow-up. The family didn't know or wasn't successful in re-engaging in the healthcare system until they brought him back to the emergency room right before his death. And it was important to me to know that the institution where this happened did an elegant root cause analysis. And they said, nobody's leaving our ER from now on until their lab results are back, and that's terrific. And I congratulate them and thank them for that. But they did not say, I wonder if this is happening in our ER every day, which it almost certainly is. It's happening in all of our emergency rooms, these diagnostic errors. So we need to find these and study these. How about the cognitive things? Well, the knowledge, I think, is sufficient. I think ER doctors know about sepsis. We already talked about the data collection problem, not looking at the CBC results. But in my mind, I think there was sufficient data to make the diagnosis. And there were two cognitive problems. One, they were in the wrong context. They were in a GI context. They heard about the nausea and the vomiting, and they're thinking it's got to be something wrong in the GI tract. So gastroenteritis made a lot of sense. And secondly, there's the problem of premature closure. I don't know if you use that term, but it's a good one to know. It means you kind of jump to conclusions. You didn't think about what else it could be. You were happy with the first explanation that came along. And this is, again, human nature, just like being in the wrong context. As human decision makers, very commonly, once we've solved the puzzle, we're happy. We don't stop and think, is there a better solution than the one I came up with? So it's bad joke time. Hey, what's a mountain goat doing up here in the cloud bank? And this is the pilots talking to each other right before the airplane crashes into the mountainside. If you study aviation disasters, or in fact accidents in any industry, these context errors are very common. So the pilot thinks he's at 10,000 feet, but it's 1,000 feet. They think they have enough fuel to get back to the airport, but they don't. Or that there's no ice on the wings, but there is. Context errors are very common. What's that middle symbol? It's a little fuzzy, but in the top line, okay, it's a V. And in the bottom line, it's a 13. Well, it's the exact same symbol. It illustrates how context determines how we make sense of things and what we think they mean. I don't know if any of you have a dog out there or a pet. Most of us, when we get our dog, we don't go and look at 10 or 20 litters. We fall in love with a puppy, and that's kind of the end. That's the puppy for us. There's a term for that, falling in love with that first puppy. Herbert Simon got the Nobel Prize for this in the field of economics. He called it satisficing. This is that human nature thing I've been talking about, where we're happy with the first solution that explains all the facts in front of us. So here's this puppy, it makes us happy, we're done. Premature closure. It's the opposite of optimizing. So an optimal problem-solving process would be to go look at many different litters and many different dogs. Or in medicine, to construct an extensive differential diagnosis and give some serious thought to other things on that list. We don't do that, we satisfice. So where are we? Well, I think we know where we are in regard to diagnostic care, and it's not where we want to be. We know that there's a lot of problems, and we have yet to really address these in any meaningful way. What could we do? Here's some suggestions from that IOM report. First, work in teams. Up to this point, diagnosis is largely a one-on-one affair. It's a clinician with the patient, and the diagnosis is pursued in that setting. But the IOM suggested that if we could make the patient, the nurse, the pathologist, the radiologist a more meaningful partner in that process, diagnosis would be safer. For example, if the patient was a full partner in the diagnostic process, if we empowered them to get back to us if their symptoms weren't resolving or got worse or they weren't responding to treatment, we'd have an opportunity to catch diagnostic errors before they lead to harm. And nurses know a lot about our patients, and they're in the perfect position to see whether the diagnoses we've assigned look like they're the correct thing. They can assess whether communication was effective. We should really take advantage of all the ways that our nursing staff could help us. Secondly, pay attention to the work environment. Reduce stress. Provide more time for diagnosis. Make it easier somehow. Provide adequate support, including a good electronic medical record system, access to decision support, access to expertise. These are all things that could improve diagnosis, and certainly focusing on improving communication would go a long way. I've been talking about the cognitive problems that are encountered so commonly, these problems of faulty context, premature closure, or heuristics that don't work. Well, fortunately, the solutions to these things would apply to all of them. So any one of the things on the right would address any of the things or all of the things on the left. So advice to practice reflectively, just stop and think, would be a very effective antidote. Consider the opposite. Okay, what else could it be besides gastroenteritis? Be comprehensive, make a differential diagnosis. So we've started to talk about universal antidotes to diagnostic error. One would be the question, what else could this be? We'd like to see patients ask that question when they're given a diagnosis. We'd like to see doctors think about this when they're considering the diagnostic possibilities. And certainly constructing a differential diagnosis would be a very effective way to accomplish that. Stop and think. There's other simple approaches we could use to be more comprehensive. This is a simple mnemonic that I have up on the wall of our rooms in our clinic and my organization, vitamin C, C, and D. So when you're seeing a patient and you're considering diagnostic possibilities, if you just simply glance at the list, it might bring to mind other possibilities than the one or two that were at the top of your list. Checklists might be an effective solution. So John Ely has prepared a very nice set of checklists. You can download them from our website, www.improveddiagnosis.org. And for any common complaint seen in primary care, here's a simple list of the problems to think about. So a patient coming in complaining of chills or feeling cold, these are the diagnostic possibilities. And you see right there on the list, sepsis is one of the things to think about. There's many electronic resources that could help with diagnosis. Some of the best are the DXplain from Harvard, Isabel. There's a new one for dermatology and general medicine from Visual DX. These are all excellent products. I do not have a financial interest in any of these, but I'd like to show one to you. Here's Isabel, and this is how it works. It's a web-based software product, so you go in there and you put in the key findings. So if we were seeing Rory Staunton, we would put in fever and vomiting and mottled skin. And within a second or two, the program makes suggestions. Here's some things to think about. And the number 2 or 3 thing on the list there over on the right, group A, streptococcus infection, which is exactly what he had. This is a study of Isabel. It was done in a pediatric ICU, and you can see that left to their own devices, the residents evaluating new patients being admitted got it right 90% of the time. It's right in line with that number we said, that 10% incidence of diagnostic error. And if they used Isabel, the software decision support product, it went up. It went up to 92%. And the attending helped as well with everybody on board, 95%. So you can look at this and you can say, you know what, that's not much of a difference going from 89 to 92%. But if you're a safety person, you look at that and you say, hey, there were 10 children at risk for a diagnostic error before that, and only 7 or 8 once we were using the Isabel system. So there were 2 or 3 children who were potentially saved from a harmful diagnostic error. And that's exactly where we are in medicine. I think we do a great job with diagnosis. I'm not here to beat up on doctors or our healthcare systems. I think we operate at a very high level given the challenges of the task. But the question is, how can we get a little better? If we're at 90%, how can we get to 92%? And this is one of the ways. How about Googling for a diagnosis? Physicians do this all the time. Horrible, horrible. Friends do not let friends Google for a diagnosis. It's not designed for that. So the sensitivity is terrible. As compared to Isabel or DXplain, the systems we've been talking about, which operate in the 95% range, Google's 58%. And the specificity is 0. The list isn't ordered at all in regard to how common one of the conditions they're recommending might occur in your patient population. So do not use Google to try and find the correct diagnosis. Here's another thing we could do, get a second opinion. Okay, this is a second opinion. I thought you had something else. So you can get a second opinion from yourself if you stop and think, or you use one of these decision support resources. But I'm also a huge advocate of getting other people involved to help you think through a case that's challenging. So ask a peer or a colleague for a second opinion on a case, or involve a medical specialist if you can. Fresh eyes are a very powerful way to catch diagnostic errors. What could patients do? This is the advice we give to patients. Be a good historian for sure. Get all the recommended cancer screenings. Delayed diagnosis of cancer is a huge problem. Keep accurate records of your own tests. Don't believe that the healthcare system is going to do that for you. Very often they don't. Speak up. You need to ask that question, what else could this be? And for sure, know how to follow up. Know how to get back if things aren't going well. And lastly, we'd like to see patients be much more aggressive and honest about giving feedback about diagnostic errors. It's very difficult if you've experienced one of these things to tell your doctor, hey, you know, it wasn't right. I really had something else. But doctors need that feedback. They really do. That's how experts become experts. They get really good feedback, and we've already seen that they're not getting that feedback from autopsies anymore. How about our healthcare systems? What should we be doing? Well, we need to start by finding and discussing diagnostic errors. That was a major recommendation in that IOM report. We need to start addressing all the system flaws that we know that contribute to these things. The low-hanging fruit are the test results that get lost, the patients who we don't follow up on appropriately. They have an incidental lung nodule that we fail to follow up on, and the next thing you know, they have metastatic cancer. We should be providing decision support resources like the ones I've been showing you. And for sure, physicians need an electronic medical record. It needs to be linked to all the other physicians in the community and to the local hospital. We need better pathways for feedback. We need to facilitate second opinions. And a great place to start would be to follow up with patients just seen in the emergency room. Call them up the next day and a week and a month later. Did we get the diagnosis right? Great way to start learning. What should physicians do? Well, you've already seen my advice. Be reflective, stop and think. Learn about these diagnostic errors and why they happen. Always construct a differential diagnosis. Take advantage of second opinion. Use these decision support resources and make the patient your partner. I have no idea which of these is the most powerful or the most effective, but I think once they're studied, they will all be effective. And what will be to our best advantage is probably to use as many of these as we possibly can. What we're doing, our Society to Improve Diagnosis, is trying to work through other organizations. So we put together a new group called the Coalition to Improve Diagnosis, where we invite leading healthcare organizations to work with us to address diagnostic error. We now have over 25 organizations on board. They're very large, important organizations. Each of them has committed to doing something individually and collectively to start addressing diagnostic error. If you're connected to an organization, please contact us. We'd like to get you involved as well. And how about the international priorities? Well, we've already said we know very little about the incidence of diagnostic error. That needs a lot more studies. We need to start thinking of what could be done now, even though we know our database is insufficient and more research is needed. What is the low-hanging fruit? What would have the biggest impact? We need to start thinking about that and discussing it. Could health informatics solve parts of this problem? And are we entirely dependent on individual nations taking action, or could we do something at a more global or regional level with telemedicine or regionally allocated resources? So there's lots to think about, there's lots to do, but this is a great time to get started on all this. This is the advice and the imperative from the Institute of Medicine. Improving the diagnostic process is not only possible, it represents a moral, professional, and a public health imperative. Let's all get to work on starting to address this. Thank you very much.